ألو.
تمام دكتور معتز، اللينك جات لحضرتك دخلت عليها. انا منتظر اللينك بتاعتنا، المفروض اهي في الطريق دلوقتي. هم بعتوا ايميل لحضرتك وايميل للدكتور وسام وايميل ليا انا والدكتور زكريا، فانا مستني عشان افتح وابقى رابط مع حضرتك حالا ان شاء الله.
ألو.
دكتور معتز سامعنا؟
أنا سامع دكتور وسام.
نعم، احنا بانتظار بس المودريتورز يدخلوا، الدكتور محمد، دكتور زكريا. بعرفش الاتنديز الان صاروا عندنا 145 so far. Hopefully in يعني a couple of minutes we'll start إن شاء الله.
إن شاء الله.
دكتور وسام، دكتور معتز.
اهلا دكتور زكريا، مرحبا. الان معنا 182 صاروا من الاتنديز وبعتقد انهم سامعيننا.
دكتور معتز سمعنا؟
مساء الخير جميعا، وإن شاء الله تكونوا بصحة وعافية في زمن الكورونا.
إن شاء الله يا رب، الله يمر أهل الأيام على خير يا رب.
آمين.
مش عارف نبلش.
I just want to make sure إنه الاتنديز are hearing us very well before we start.
من الشباب حدا سمعنا؟
على الشات they say إنه سامعين. I think there are some attendees who are not Arabic speakers also. I think they are hearing us.
We are going to speak in English.
Okay.
Bismillah ar-Rahman. Dear doctors and colleagues, good afternoon everybody. With pleasure to have you today in our ophthalmic webinar organized by Middle East Eye Hospital in cooperation with Jordanian Ophthalmic Society and sponsored by Orchidia Pharmaceutical Industries. Our speakers today, Professor Dr. Mu'taz Gharaibeh and Professor Dr. Wissam Shhadeh. I want to thank Jordanian Ophthalmic Society, represented by Dr. Mu'adh Arabiyat, and Middle East Eye Hospital, represented by Dr. Musa Baidoun, General Manager of the hospital, who supported and hosted this scientific event. And also I thank Orchidia Pharmaceutical Industries for supporting this event. Our first speaker is Professor Dr. Wissam Shhadeh, the Dean of Faculty of Medicine in El Yarmouk University, Jordan, Senior Consultant in Corneal Disease and Surgeries. And his talk will be about decision tree for patients with keratoconus. Dr. Wissam, please.
Well, thank you very much, Dr. Zakaria. First of all, I would like to make sure that everybody is seeing my screen and hearing my voice well. For the attendees, I can see above 200 attendees now. You can communicate with us through the chat. And please let me know if there is any technical problem before we start. Thank you again, Dr. Zakaria. I'm honored to be here today, and hopefully these difficult days will be soon away, inshallah Rabbil Alameen. Again, I would like to thank everybody who had the effort and time to organize this meeting, and hopefully it will be a useful one. I would like to thank the Jordanian Ophthalmology Society for the continuous efforts during the lockdown to be always in touch scientifically. And also I would like to ask or thank the Middle East Hospital for the kind invitation. And also I would like to thank Orchidia for, again, the continuous organization of the scientific gatherings and meetings. In my presentation today, I'll be going step by step in a systematic approach to deal with keratoconus patients. As you are all aware, keratoconus is very, very common in our area, in the whole Mediterranean area, and particularly in the Middle Eastern area. And most of the information that probably I'm gonna go through in this presentation is sort of well known to all of you. And my presentation, the goal of it is just to go through that step by step in a decision tree fashion. I have nothing pertinent to disclose for this presentation. As you all know, corneal ectasia is a group of non-inflammatory disorders characterized by corneal weakness or thinning, in which the protrusion of the cornea leads to irregular astigmatism and poor visual acuity. And this is a large group of disorders that comprises primary conditions like keratoconus, keratoglobus, and PMD, in addition to the secondary or iatrogenic causes like the corneal ectasia following refractive surgery. whenever you face any patient with keratoconus, you have in mind two goals of treatment. The first goal is to stop or delay or herald the progression of the disease. And the second goal is, of course, why the patient is coming to your clinic, is to improve and restore and cause visual rehabilitation for the patient. So again, when you face a patient with keratoconus, you keep always these two goals in your mind. First thing, you have to stop the disease because it's a progressive disease. And the second goal is to restore visual acuity and visual rehabilitation. I can see another voice actually
طيب ادي المودريتور هو فين بقى؟ شايف 227
Dr. Zakaria, can you hear me, Dr. Zakaria?
Yes, yes.
Okay, because I can see a different voice, one of our friends speaking in Arabic, so I thought, no, it can cause some disturbances for the attendees. I hear that there is no problem with hearing from the chat that I see, so I'll continue for the sake of time. Again, this is my approach to deal with patients with keratoconus, or this is my decision tree. It's not something that I invented. It's not something that I wrote. It's just a summary or a collection from what I came across in the literature. And also I added from my journey with keratoconus patients over the last probably 15 years or more, what I felt that it's different in our community from other communities. So the first question that you have to ask yourself whenever you face any patient with keratoconus in your clinic is your patient progressing or not? That's a very important question because the whole plan of action will be different if the patient is progressing, different from the patient that's stable and have a stable cone. So the first question, again, you have to answer this in the first visit that you see the patient. Is your patient progressing or not? Sometimes you will not be able to get an answer in the first visit because you don't have any previous history of the patient, you don't have previous images for the patient, and you might need to follow up the patient to define this question. And sometimes you have a clue and you will be able to take a decision from the very first visit to your clinic. In order to answer this question, we need to know the definition of progression. And I was hoping that we had more interactive actually session to be able to listen to the attendees and know their approaches and their definition of progression, but that's not the case now. So I'll go for the next slide to show you what I consider progression. Now, there are many definitions. If you go through the literature, there are many definitions for progression. More or less, they are talking about probably the same principle, but again, you have to have solid numbers to decide whether your patient is progressing or not. It's not only an impression that you develop. You have to have something in your hand that you can rely on to say that, yes, my patient is progressing. Now, one of the definitions is the one proposed by our friend, Professor Mazen Sinjab in his academy, where he defined progression as an increase of 2 diopters on the Kmax and decrease in the corneal thickness of 15 microns on the thinnest location. And the two things should be there to define progression. So increase of 2 diopters or more on the Kmax and thinning of 15 microns or more on the thinnest location. Now, the interval doesn't really matter because some will ask, should I do it every 2 months or every 3 months or every 6 months? It depends on your patient. If your patient is young, having bad behavior in one eye, probably you'll do it more frequent, the test and the topographies. But if the patient is relatively old, like patients above 30, I might do it every 6 months or every even 1 year. So if you prove this, that means that your patient is progressing. Another definition that came out from Ashiwari group in 2013, they defined progression as an increase of half diopter or more on the steep meridian in 2 sagittal curvature maps and 10% decrease on the thinnest point. And that's 6 months apart topographies. So again, this is another definition of progression of keratoconus. And to make life easy, always technologies come to help surgeons and physicians and ophthalmologists to take decisions. Now we have the software that you can purchase and upload to your machine, which is called the ABCD Keratoconus staging software, and that also can give you an answer if your patient is progressing or not. It helps you. It doesn't give you the whole answer because your impression as a clinician, as a doctor, will count the most. But at the same time, it will give you a very good idea. So those are the definitions of progression. Probably you have other definitions, but again, you have to be consistent dealing with who is patient is progressing, and to be able to get consistent results, it's better to compare images and topographies on the same kind of machine. I wouldn't recommend to compare a pentacam to an Orbiscan. And even I would like to compare the pentacam if you can on the same machine, but that's not possible all the time because some patients come from outside or from other clinics or other centers with pentacam in their hand. But at least try to compare topographies on the same machine. Pentacam, Orbiscan, if you can do that. Now, if you decide that your patient is progressing, we go back to the decision tree. That means you know, and I know, that the patient needs cross-linking, because cross-linking is the only proven modality nowadays to stop the progression of the disease. There is no other modality that stops the progression of disease. There has been a lot of talk about the rigid contact lenses, about the scleral contact lenses, about the rings. There is no real evidence in the literature that proves that those modalities stop the progression of disease. The only one proven to stop the progression of disease is the cross-linking technique. And again, cross-linking is one of the really talks that I love to talk about, but it's a very lengthy talk, and probably it needs more than one lecture to talk about it. So I'll just go quickly in a couple of minutes about the techniques of cross-linking, because you've been hearing a lot about the techniques and the development in cross-linking nowadays. The original technique, the one proposed by Theo Seiler, the gentleman in this photo wearing the red tie, though he proposed it in 2003, which is like 17 years ago. So we have now long-term data to assess and analyze the efficiency of the procedure. He proposed the Dresden protocol, which is an EP-off technique and the standard EP-off technique, where you do 30 minutes of saturation with riboflavin or imbibition with riboflavin, and then 30 minutes with the irradiance with UV light. And the classical one was 3 milliwatt per centimeter square for 30 minutes. And this is still a technique that's very efficient, and we have very good results with it. However, the newer techniques came for many reasons. One of the most important things is to shorten the procedure time, because it was really too long to keep the patient for 1 hour in occupying one of the rooms in the OR, or even as an outpatient, he's occupying one room, occupying 1 or 2 technicians, in addition to the doctor coming in and out. So it was a very lengthy procedure. So the new modalities, one of the main goals to invent it were to reduce the time of the procedure, either reduce the imbibition time, the saturation time, like we see in the iontophoresis, or by reducing the irradiance time, that like we see in the accelerated cross-linking. The total irradiance that should be delivered to the cornea is 5.4 joule per centimeter square. Whether you are using the accelerated, you can increase the irradiance on the expense of time. For example, we have machines that give you 9 milliwatt per square centimeter for 10 minutes, or it can give you even 18 milliwatt for 5 minutes. So the total power or the total irradiance delivered is around 90 milliwatt per centimeter square, which is equivalent to 5.4 joule per centimeter square. We usually don't go less than 5 minutes in irradiation, because the efficiency will become less and less because of oxygen depletion. In iontophoresis, it is pretty much the same principle. However, you keep the epithelium on and you enhance the penetration of the riboflavin by using electrodes to push the riboflavin through the intact epithelium. And nowadays also they are talking about Avedro introduced a technique talking about oxygen boost cross-linking, where again you keep the epithelium on and the patient wears special goggles that gives him an oxygen boost, and this oxygen boost will help as an enhancer to improve the penetration of the riboflavin into the stroma. So again, different modalities, different techniques. The principle is the same, is to get the collagen fibers in the cornea to get cross-linked and to have the patient heralded his progression of keratoconus. And finally, the customized cross-linking, which is cross-linking for the affected area. The principle is that we are treating that diseased area. Why should I treat the whole cornea, ended up with some potential complication, if I can treat only the affected or the protruded or the keratoconus part of the cornea? So that's in Harry, the cross-linking techniques that we use nowadays. So the patient had the cross-linking, and we're done with the first part of the treatment, which is stopping or delaying the progression of the disease. Of course, we need to keep in mind that this patient still needs monitoring in the future to make sure that our cross-linking is effective and that the disease is really stopped. Now we'll go to the second part of the treatment, where you will need to increase or to improve the visual performance of the patient, because this is what the patient is caring about. The patient is seeking better vision. When you do cross-linking, he is not having better vision yet, and he might not be happy because he will say that his vision is even worse than before the cross-linking, because after cross-linking, we know there might be some haze that will reduce the vision for a short period of time. So the patient is always seeking visual improvement. And in order to achieve this second goal of the keratoconus treatment, we look at the best corrected visual acuity. If the patient can refract to a good visual acuity, and here the cutoff point, we are talking about 0.3 and above, then you can consider treatment of this patient with one of two tracks. If the patient is having low refractive error, after cross-linking, the patient might be very, very happy with the glasses, because patients with low refractive errors, they do very well with the glasses, and they usually don't suffer a lot of aberrations, and it's a very safe thing. So you do the cross-linking, you give the patient glasses or spectacles, and that's it. And the patient keeps coming every now and then to check again for the success of cross-linking and the potential of progression. If the patient is not willing to wear glasses for one reason or another, he can go for the contact lenses. And in low refractive errors, even the soft or the soft toric contact lenses can help. And there is the controversial issues. This is a very controversial issue, the PRK following cross-linking in patients with low refractive error. We'll talk about it, but again, it's a controversial issue, but you should know what's going on in the world in terms of PRK for cross-linking. Now, if the patient is having high refractive error, the order of improving vision is different. They usually don't do well with the glasses because of a lot of aberrations, so they cannot tolerate spectacles with high refractive prescriptions. They do much better with contact lens, and now contact lens development has been way better than years ago. We have the scleral contact lenses that are tolerable by a wide variety or wide range of patients. And also we have the option of Toric ICL, which is again an off-label use, but there has been an extensive literature on Toric ICL for keratoconus patients with good vision. And as I said, spectacles for high refractive errors are usually not the fair choice for the patient. Now, the surface ablation or the PRK for keratoconic patients. Now, before I go through this slide, you have to realize a few things. First of all, it's a controversial issue because you will say, okay, I will do it. Your colleague will say, no, this is absolutely contraindicated. And the patient should understand this, that this is a controversial issue. The second point you should understand is that we are not talking about refractive surgery here. It's not like PRK for a patient coming just for refractive surgery. It's not a refractive surgery. It's a surgery that we do only to regularize the cornea. We cannot promise the patient to get rid of refractive error that he has. We're telling the patient that we will try to regularize the cornea to make the refractive error less than what you have, but you will need spectacles, most likely. You might need contact lenses, and you might need to repeat the cross-linking in the future, because after doing PRK, we are basically ablating part of the cross-linked cornea that we've done before. So you have to counsel your patient very, very, very well. Now, the first one to introduce the technique Athens protocol was Kanellopoulos. And Kanellopoulos in 2012 did simultaneous PRK and cross-linking. And, you know, it took like popularity all over the world. And for almost 2 years, everybody was a big fan of the procedure. I myself, I did, if not more than tens, probably 100 of such patients, simultaneous cross-linking and PRK. I'm not doing it anymore, actually. I'm not happy with the results, and I don't recommend that you do it. If you want to do PRK, it should be after cross-linking. And again, you should keep in mind the precautions that I told you about. But don't do simultaneous PRK and cross-linking. I've seen a lot of catastrophes following such procedure. Now, Toric ICL still is an option for patients with stable keratoconus. So you need to make sure that your patient is stable. So we don't do it before 6 months after cross-linking, just to make sure that the cornea is stable. Second of all, again, you tell the patient that this is not a refractive procedure. I cannot promise you to get rid of all the refractive errors. We reduce the refractive errors dramatically in terms of sphere and cylinder. But again, I cannot tell you that you will be 0 refraction. You might need to wear spectacles after that. And in spite of excellent correction of the refractive error, those patients, they usually suffer from some disturbances in the visual quality, and that's related to the high order aberrations because of the abnormal cornea. But again, it's a very good technique. It's an easy technique, relatively safe technique. And if you select the right patient and you do the right measurements, which are a challenge actually, you can end up with really, really good results. Again, remember, patient with ICL because he has high myopia is different from a patient with keratoconus going for an ICL. Always keep that in mind. And you should tell the patient about that as well. Okay, so we're done with this part of the tree, which is the patient who can get good refraction with either low refractive error or high refractive error. Let's go to the other part of the tree. If the patient is not having a good refraction, I mean, he doesn't refract to more than 0.1 or 0.15. Whatever you do, the patient doesn't refract to really good refraction. Here you have to check again the cornea. If the cornea is clear, your way of thinking and your way of management is different from the patient who's having corneal haze or corneal scar. Let's go with the straightforward one. If the patient is having a clear cornea, the next step is to look for how steep the cornea is. If the cornea is too steep, and we mean by too steep, above 65, the K readings, I think the only option left for such a patient is DALK, deep antillar lamellar keratoplasty, because all other techniques cannot be done. You cannot fit a contact lens over such a steep cornea. You cannot do cornea rings for such a steep cornea. And of course, you cannot do the other procedures that we just mentioned for a steep cornea, because you cannot do even refraction for such a patient. But if the patient has less than 65 K readings, which means that his cornea is steep, but it's not too steep, still you have the option of doing cross-linking for the patient, although the results of cross-linking in such steep corneas are not great. This is why some people, they say, no, I don't do cross-linking above 60. It's not contraindicated to do cross-linking above 60, but the results and the outcome of cross-linking after 60 is not that great. So I do, as long as the corneal thickness allows me to go for cross-linking, I do cross-linking for such patients, and I recommend also for such patients to do corneal rings. I'm not going to spend time on corneal rings because we rarely do it nowadays. Corneal rings, I started doing it in 2007. Probably I've done more than 500, 600 corneal rings over 3 years. But then after that, probably from 2010 till now, probably I didn't do 10% of that number. We rarely do it nowadays because we have better options. But again, you should know that there is still a place for corneal rings. Whenever you have a patient that cannot refract well and has a clear cornea, in contact lens intolerance, you cannot do anything for this patient except ring. Again, think with me. The patient cannot be refracted to a good visual acuity. His vision is like 0.1. At the same time, he is intolerant to contact lenses. Spectacles do not help. PRK cannot be done. ICL cannot be done because you don't have refraction and measurement for the ICL. And still, he didn't reach the stage of corneal grafting. So what will you do for the patient? This is the only option that you have in such a patient. And you face in the clinic such a patient every now and then. Remember, a patient does not refract well. He refracts only to 0.1. This patient intolerant for contact lens. You cannot do on such a patient toric ICL. You cannot do PRK for such a patient. You cannot do spectacles or glasses for this patient because you cannot do refraction for him. So this is the only option left. What I'm trying to say, although corneal rings, we don't do it as we used to do it in the old days, but still there's a place for corneal rings nowadays. Of course, you cannot do it if the patient is having corneal haze, advanced keratoconus, hydrops, infection, or too thin corneas. Back to our slide and decision tree. We're done with all this. We are left with this category where the patient doesn't have a clear cornea. In such a patient where the patient doesn't have a clear cornea, that means the cornea has a scar or a haze. In this case, actually, you look for the scar either on the slit lamp or on a OCT or on a shine plug image, and you can decide the depth of the scar. If the scar is superficial, I would definitely recommend to go for the DALC procedure. But if the scar is all through the whole thickness or a very deep scar, the only option that you are left with is penetrating keratoconus. Here, there should be a video, but for technical reasons, I will not be able to run it. But what I'm trying to say here for corneal surgeons, that you are all familiar with penetrating keratoplasty. Deep anterior lamellar keratoplasty, which is DALC, is easier. Again, I stress again, it's easier than penetrating keratoplasty because you are dealing with a closed system, a very safe system, and there is no risk of doing it and starting with it. You don't need special instruments. You can use only the instruments that you have in the OR. You don't need to buy or purchase anything new. And again, what's the worst case scenario? Think about it. The worst case scenario is that while you are dissecting down to the descemet membrane is to cause microperforation in the descemet membrane. So what? If you cause that large perforation, you can easily convert to penetrating keratoplasty that you are familiar with. But if the procedure goes well, you can end up with much better results. No endothelial rejection, faster recovery, etc., etc., etc. So I encourage here in this talk everybody to start doing the ALK, but you have to select the right patient. And again, keep in mind it's a safe procedure. It's safer than penetrating keratoplasty. It's easier than penetrating keratoplasty. And in the worst case scenario, if you perforate, you can easily go and convert to penetrating keratoplasty. Now I'll try to end my presentation for the sake of time with just one clinical scenario that I actually introduced. It's not a real patient, but I try to simulate a patient to try to summarize what we had in the decision tree. Suppose that we are dealing with a 24-year-old male patient with poor vision, and his vision in the right eye is 2 meters, not improved with refraction. And this is the way he looks on the slit lamp, very advanced keratoconus, central corneal scar. And I'm not expecting answer actually to have an active interactive discussion, but I'll go through the discussion from different points of view. Now, for such a patient in the right eye, I don't think that we have a lot of options, because if we go through everything that we thought about in the decision tree, it doesn't work here. Of course, you cannot do cross-linking on this patient, although you know deep in heart that he is progressing, because I think that this cornea is not more than 200 microns in the center. Second of all, you cannot fit a contact lens on such a patient because of the very steep cornea. Third of all, you cannot definitely give him glasses because we said it doesn't improve the refraction, and so you cannot do neither toric ICL or any refractive procedure on such patient. So you are left with no options in such an eye except grafting. Now, which kind of a graft? Again, it's determined by the depth of the corneal scar that you have. So you have to assess probably in the slit lamp very properly, and then you can confirm that with either anterior segment OCT or the shine plug image that you have in your pentacam machine. So for such an eye, the only option you have is corneal graft. Let's go for his other or better eye. This is the left eye. This patient is having better vision in the left eye with a clear cornea. Now, the first message I would like to deliver from this case scenario is that would you do cross-linking or not on this patient? And how long will you wait before doing cross-linking? Will you wait to confirm that this patient is progressing or not? In this case, I wouldn't recommend to wait any single day, because you know that this patient, the keratoconus disease in such a patient is behaving really aggressively, because you have an evidence in the right eye, and you know that this eye will go down the hill very quickly if you don't stop the progression of the disease in such patient. So in such an eye, I wouldn't go through the decision tree and say, okay, I'll wait for 6 months, repeat the topography, make sure that the topography is stable, etc., etc., etc. You know that he is 24 years old, so he has many years to progress. You know that he is behaving very bad in the right eye. You know that this is his better eye, so definitely you need to go for cross-linking from day one. You should not wait to confirm progression. This is the first message I would deliver here. What kind of a cross-linking? It depends on the cornea thickness. If the cornea thickness is relatively in the good side, good thickness, and we mean by that above 450, I would recommend going for AP of isotonic to make sure that it's an efficient procedure. If it's less than 450, 400 to 450, if you want to do the AP procedure, you have to use the hypotonic saline in order to swell the cornea and take it to a higher thickness. And if it's less than 400, this is a real challenge, because if it's less than a 400, would you cross it? The classical teaching that you cannot progress a cornea or cross-link a cornea below 400 because of the risk of the endothelial damage. Okay, but think about it. This patient is having this only eye for the time being. Okay, and even if the procedure outcome of cross-linking is not that great, but it's better than nothing, because you know if you leave him alone, he will progress. So for such a patient, any thickness above 350, I will cross-link this patient. Of course, there are different modalities. If the patient is having 350 to 400, you can use either the contact lens assisted cross-linking, or you can use the ionophoresis, the AP-on technique, or the oxygen boost AP-on technique. So there are modalities to deal with such cornea. But if the patient is having less than 350 cornea, then you are not having any options, and you need to just monitor the patient, avoid eye rubbing, and keep seeing him every now and then till he reaches the stage of grafting. So by that, I will end my presentation, and I'm very happy to be here today, and hopefully the coming days will be better, inshallah. Thank you very much.
Thank you, Dr. Wissam. Thank you very much. We have some questions. Can we depend on keratometry only to confirm progress?
Not really, because in keratometry, actually, you have a lot of flaws in the test, and you have to confirm the Kmax on a real topography machine and the thinnest point on a real topography machine. So keratometry is not a dependable, accurate procedure to assess progression of keratoconus.
Thanks, of course. Can we perform PRK first, then cross-linking?
Yeah, again, I repeat that this is a very controversial issue. There were 3 ways to deal with this. First, would I do PRK and then cross-linking? Or should I do PRK and cross-linking at the same time? Or should I do cross-linking first, then PRK? Every procedure has advantages and disadvantages. If you go for PRK first and then you do cross-linking, first of all, you will change the refraction of the patient after doing the second cross-linking. So you are doing a PRK on unstable cornea, and after doing the cross-linking over that, you will change the refraction that you got after doing the PRK. So the answer is no. Would you do simultaneous, both together? Yes, you can do according to Athens protocol, but I'm giving you my own experience. It doesn't mean that it's the right thing, but this is what I'm convinced with, and I think most of the world is going in that direction. Doing simultaneous PRK and cross-linking is not a good option. You can end up with massive amount of haze. You can end up with very unpredictable results, and you can end up with unexpected complications. I think among the audience here, we have almost 300 audience. I think at least 10, they are aware of one of the cases that was referred to me from a colleague. A colleague did cross-linking and PRK at the same time, and the patient ended up with melting. It's not frequent, but it can happen. It was really a difficult procedure. I ended up doing a very large graft, reaching even the limbus to take care of all the melting. So again, doing simultaneous is not a good option. Is not a good option in my point of view. The only option that I do, and rarely, I don't do it frequently. I do it rarely. First, I do cross-linking, and then 6 months after the cross-linking, when I realize that the patient is stable 100%, I consider correcting part of the refractive error, not taking more than 50 microns of the corneal thickness in order to regularize the cornea, as I said before.
Okay, this is my question. What about toric IOL or ICL, and what is the success rate, you think?
Well, again, it depends on the stability of the cone. If the cone is stable, and you need to confirm that 6 months after the cross-linking by doing all the imaging needed. If the cone is stable and the patient is having a good best-corrected visual acuity, according to the literature and in my hands, I really had good and satisfactory results. I mean by satisfactory results, the patient is happy. I'm having a vision almost 0.6, 0.7, which is like 6.9, and the patient doesn't depend on the glasses most of the time. But you cannot do it for a patient who has unstable cone. You cannot do it for a patient who doesn't refract well. For example, if your patient has a stable cone, but you sent him for refraction, and the best result that you can reach with refraction 0.2, this is not a good candidate because he will not improve after doing a toric ICL. You have to have a good best corrected visual acuity, and you have to have a stable cone. If those two conditions are there, you can end up with really good results.
Okay. Here we have a very good question, I think. What are the signs of failed cross-linking?
Again, you can apply the same definition of progression on failed cross-linking. If you end up with increase of 2 diopters or more on Kmax, reduction of the corneal thickness after 6 months, this means a failed cross-linking. Of course, you don't do the cross-linking right after, because after cross-linking, if you do it corneal thickness after cross-linking 1 month after, all the corneas, they do have thinner cornea, because after cross-linking, the cornea is sort of dehydrated, and it takes some time for the remodeling of the collagen fibers to get back to the usual cornea thickness. But again, if you do it after 6 months and you have increase of 2 diopters on Kmax and more than 15 microns thinning on the thinnest location, this is considered a failure. But luckily, we don't see a lot of failures, especially with the epi-on techniques. You have to be aware if you are doing an epi-on technique, you will face a significant number of, let's say, repetition in comparison with the epi-on technique. So epi-on technique is still more efficient, but again, it carries the risk of the epithelial removal, which is pain, haze, sometimes infection, etc.
When you are going to repeat the cross-linking, if there is any failure?
Not less than 6 months. And again, that depends on many variables. If I'm having a young patient, like a patient who is 18 years old, and with bad history in one eye, like the other eye is going for a cornea transplant, I will do it earlier than a patient who is like 30 years old with good vision in the other eye. But again, definitely, you cannot repeat it before 6 months, because if you do that, the corneal nerves are still not regenerated, the keratocytes are not back to normal, so you'll induce a significant amount of not only haze, but also scar.
Okay, here we have another question, please. Do you do topography guided or wavefront guided PRK after cross-linking or not?
Yeah, this is a good question because there has been a lot of literature. Now, most of the evidence says that topography guided PRK after cross-linked corneas gives better results than wavefront PRK. So in order to answer your question straightforward, I do topography guided PRK, not wavefront guided PRK.
Okay, please, another question. What about the age, maximum age and minimum age that you can perform the cross-linking?
To tell you the truth, there is no minimum age, there is no maximum age. But I'll give you some facts. We rarely see progression of keratoconus after the age of 40. However, there has been some reported cases after the age of 40. Very rare. And I'm talking about keratoconus. I'm talking about primary keratoconus. I'm not talking about pellucid marginal degeneration, because pellucid marginal vision can deteriorate after the age of 40. I'm not talking about post-LASIK ectasia. Post-LASIK ectasia can deteriorate even after the age of 50. I'm talking about primary keratoconus. We rarely see it deteriorating after the age of 40. But again, there is no rule that above 40, I don't do it. If there is an evidence of progression above the age of 40, and the patient coming to you saying that I'm having deteriorating vision, and you can prove that with serial topographies, still, there is no contraindication to do it. But I don't recall that I've done any after the age of 40. None, zero. No minimum age. We used to say that keratoconus comes after the age of puberty, 13, 14. This is not true. I've seen a patient who is 9 years old. In the literature, there are some cases reported 7 years old. So you can do the cross-linking as early as you discover your patient. However, the technique will be more difficult because a 7-year-old boy will not be able to cooperate doing cross-linking under local anesthesia. So I had to do it under general anesthesia. So the technique will be different, but there is no minimum age. Whenever you discover keratoconus and you prove that this keratoconus is progressing, you have to go for cross-linking.
Thank you very much, Dr. Wissam. Thanks. It was very, very beautiful discussion. Please let us see this video.
Thank you very much. An honor to be with you all. Thank you, attendees.
Then we are going to the second professor, Dr. Mu'taz.
Hello.
Yes, Dr. Mu'taz, we can hear you.
الو مساء الخير جميعا. مساء الخير جميعا.
Dr. Mu'taz. Our second speaker, Professor Dr. Mu'taz Gharaiba, Senior Consultant in Pediatric Ophthalmology in the Faculty of Medicine in the University of Jordan. And his talk will be about congenital cataract surgery, the better piece of cake. Please, Dr. Mu'taz.
مساء الخير. Good afternoon. Bonsoir. Buenas tardes. I'm sorry that some of our attendees were asking for a French translation. Unfortunately, we cannot do it, but hopefully next time. I'm really honored to be here. I don't know how much I will be that informative after the very excellent speak of Dr. Wissam. I'm trying to make it as short, as precise, as to the point as possible. Hopefully you can see my screen. Can you see my screen now? Dr. Zakaria?
Yes, Dr. Mu'taz. Yes, please.
Okay.
Please.
So
everything is okay, please.
So we are talking about a congenital cataract surgery. First of all, I have to say that I don't have any financial disclosure. So congenital cataract surgery is easy. And as you know, you are doing a surgery in a patient who is asleep, very cooperative. You do not need to do phaco, which means that you do not need to crack. You do not prefer to do stop and chop or divide and conquer, or whatever technique you would like to, superior approach, temporal approach, etc. And the most important thing in doing cataract surgery is that you will rupture the posterior capsule anyway. So that's a good thing. And after you are done, you will just send him over for visual rehabilitation. This is what so far we know about congenital cataract surgery. Well, I hope it's that. A few things in life, they are really different when they are young than they are old, and some of them are totally different. And in ophthalmology per se, we know that who deals with congenital glaucoma patients, dealing with kids is totally different than dealing with adults. So the pediatric or the infantile or the juvenile eye is definitely not a small eye only. Okay, so we have a lot of dilemmas in dealing with congenital cataract patients. Not starting from the etiology, are we going about talking about unilateral or bilateral cataract? Will you operate or not? And if you are going to operate, when you will operate? Are you going to put an IOL? If you are going to put an IOL, when and what type of IOL you will put? How you will manage your postoperative inflammation? What are the possible complications? What visual rehabilitation issues you have, etc., etc. So the piece of cake is just deciding to do the surgery. The better piece of cake is the surgery and its pre and post issues. To operate or not to operate, which is a question that we usually face when dealing with congenital cataract patients. Do we have to operate our patients? Well, of course not. That depends on many factors. Ophthalmic condition is one of them. If this is your patient and you are talking about a microphthalmic eye, a unilateral cataract in a patient who looks like a PHPV, then you have to wait and say, should I really operate if this is the full-blown picture of the PHPV, especially if your axial length is below 13, or I will just go and do the surgery if you are talking about the fine fibrovascular band that's extending from the optic nerve to the lens, and you think that he has a good visual potential. Of course, there are other factors that determine should they go or not for surgery. What's the type of the cataract that you are dealing with? Is it a progressive type of cataract that you really have to interfere early? The size of the cataract, the location, what's the visual acuity of the patient? Are we talking about a patient who has a visual acuity of 0.3, where should I go for a cataract surgery in this 4-year child, or I will just wait, etc., etc. A lot of issues. I think they are beyond the scope of this presentation, so I just skip them. Unless somebody is interested, we can discuss it in the discussion. Okay, so the classical approach for the timing of congenital cataract surgery is as follows. If you are dealing with a monocular cataract, then surgery and optical correction should be done by the age of 4 and 6 weeks of age. That's to try to decrease as possible as you can the amblyopia. If you are talking about a bilateral cataract, then you might defer it for 2 more weeks, but definitely surgery and optical correction should be done by the age of 4 to 6 weeks of age. And a very important fact when dealing with congenital cataract patient is that aphakia is as severely amblyogenic as having the cataract. So doing the surgery alone is not the optimum that we are looking for. Okay, when dealing with unilateral cataract and bilateral cataract, we have a major difference. We have a lot of differences, but the major difference that we're talking about is if you are talking about unilateral cataract, then maybe you have to address the eye. Are there any ophthalmic abnormalities? If we are talking about a bilateral cataract, then we are talking about the body in general more than the eye. And sometimes doing cataract in a bilateral cataract patient will not be possible, not because we are not able or we do not want to, but because the patient will not allow us. And just a tiny bit of information, if you think that you have a unilateral cataract patient and you have to dare to defer the surgery for 1 or 2 weeks, then maybe patching both eyes will be a good idea till you plan his surgery, because this will decrease the severe amblyopia that happens from pattern deprivation amblyopia. Okay, so as we all know, congenital cataract surgery is just a piece of cake. You will go, you will aspirate the lens, you will do proper posterior capsulotomy with anterior vitrectomy. You might or may not remove the IOL. Well, this is the classical teaching. We are right with that. But how about the rixes in the children? Let's go step by step. Is it the same? For those of you who do a lot of cataracts, this is the perfect rixes that you really want to see. Very well circumcised, 5 millimeters, centralized. Well, for those of you who deal with kids or with infants or even with juveniles, you know that the capsule is very elastic. So this is not what we usually go for. In capsule rixes in children, we know it's very elastic, so we do what we call the spiral rixes. You start with the small rixes and you start to increasing it gradually until you think that you reach the diameter that you want to. Of course, doing this, you need to do it under a really heavy viscoelastic. You name it, I don't have any preference. Helon GV, Provix, Amvisc. You need a flat or even a concave capsule to do this. And while doing the rixes, you have to be really directed toward the center, because while you are doing the rixes, you are pushing this way, but actually the capsule extending that way. And if you have an extension, then because we all know that phacoemulsification is not forgiving. Step 2 is almost 100% dependent on step 1. This is exactly where we say that phaco is not forgiving when we're doing it with congenital cataract, because each step is completely dependent on the previous step. Okay, how about the lens? Well, as we said, we will just go and spread the lens. You do not need phaco. But how about if we are dealing without a posterior polar cataract? Well, for those particular patients, we know that if you have a patient with a posterior polar cataract, then you have a 26% chance of a defective posterior capsule that will be open. Once you are in, the posterior capsule is open. And if it's not open, then you have a 36% chance that you will rupture the posterior capsule. Are there any signs that might tell you that we are dealing with a ruptured posterior capsule? Well, yes, the fishtail sign, that are some small, tiny white opacifications in the anterior vitreous, or if you are seeing these concentric opacities around the central cataract, then yes, we are dealing with mostly with a ruptured posterior capsule. So any precautions that I might use to avoid posterior capsular rupture if it was not there? Well, actually there are some. In those patients, we try to avoid the buildup of the fluid inside the bag. Try to use a heavy viscoelastic, a heavy viscocohesive viscoelastic, actually. You need really low phaco parameters. Your bottle height should, you might not need a bottle height more than 50. Your vacuum should be maximum 140, 150 millimeter mercury. Very important point in those patients, never do hydrodissection. Do hydrodelineation, and what I personally prefer is to do an in-out hydrodelineation. That where I start from the center of the lens, going slowly, gradually outwards to delineate the lens, but definitely not to hydrodissect it. Okay, we remove the lens. Should we remove everything? Or should we leave something? Actually, this is what we as pediatric ophthalmologists prefer to leave, what we call the Sommering ring, because later on we will need it. So if you are going to clean very well the nucleus and the cortex, but leave some of the very peripheral cortex, because you will need it later on if you are going to put in the bag lens. As we said, do not be afraid of the posterior capsule. Well, I personally prefer to do a controlled primary posterior CCC. So I intentionally opened the posterior capsule if it was not opened. I put some some viscoelastic behind the posterior capsule just to cut the liquid ligament. Do a controlled posterior capsulotomy. And you definitely need to do an anterior vitrectomy. Some people prefer to do this after they put the IOL. They think it's more stable. Well, you can do that, do whatever you want, but doing that after you put the IOL will not be as controlled as if you do it primarily. Why should we do that? Well, actually, because visual axis opacification is the most common complication observed after cataract extraction in children. So that's why we do it. Should we do it in all patients? Definitely yes, because if leaving the anterior vitreal phase will allow peripheral lens epithelial cells to grow, and this will cause visual axis opacification more and more. And unless you want all your patients to go for this, and you have the capability to do this, then yes, you have to do a posterior capsulotomy and anterior vitrectomy. Again, the age of the patient decides whether you will go to primarily or will just wait. But for all patients below the age of 3 or 4 years, maybe, definitely you need to do this. Okay, let's go to some evidence-based medicine, because this is what I really like. Are we going to implant an IOL? Why, when, and what? Well, why? Simply because we know that inserting an IOL will decrease the risk of retinal detachment and the risk of cystoid macular edema in all patients, not only in the pediatric age group. So, but when we implant an IOL in children, we know that there is a higher rate of secondary cataract, or what we call the after cataract, in the lensectomy and IOL patients compared to the lensectomy only patients. So if you put an IOL, then you expect that your visual axis opacification chance will be more, even if you did a posterior capsulotomy and anterior vitrectomy. In this study, Greenwald showed that posterior chamber IOL implantation appears to provide significantly better binocular function than conventional management of unilateral cataract. We'll talk a little bit more about that later on, but this does not substantially improve visual acuity. So putting an IOL or not, your ultimate goal of having a good visual acuity will not differ that much. So we put an IOL simply to decrease the cystoid macular edema and the retinal detachment chance. When are we going to put it? Well, this is a very controversial issue. You will hear a lot of that. Our two evidence-based studies that we usually rely on actually are those two studies. The infant phakia treatment study and the IOL under 2 cohort study. Okay, in the IAT study, which is a very well-known study, there was no statistically significant difference in visual acuity at the age of 1 year between those patients who had an intraocular lens before the age of 2 years and those who were treated only with a contact lens group. And caution should be exercised when performing intraocular implantation in children aged 6 months or younger, given the higher incidence of adverse effects and the absence of an improved short-term visual outcome compared with contact lens use. Most of these additional operations that we saw when we were implanting an IOL were performed to clear the lens reproliferation and pupillary membranes from the visual axis. But one of the very well-known drawbacks for the infant phakia treatment study is that it was done on unilateral cataract, not on bilateral cataract. Okay, these are the tables for the 5-year follow-up for those patients. What happened after 4.5 years average of follow-up for those patients? There was not any statistically significant difference in the visual acuity between the two groups. And what we really noticed that after 5 years of follow-up for those patients, the rate of myopic shift occurs most rapidly for those patients who had an intraocular lens, especially during the first 1.5 years of life. So one of the good conclusions for this study that we rely on later on is that this myopic shift really varies substantially among patients. And if our goal is emetropia at the age of 5 years, then our immediate postoperative hypermetropic target should be 10 diopters at the age of 6 weeks and maybe 8 diopters at the age of 6 months. However, even using these targets, you have to know that it's likely that many children will require additional refractive correction, giving the very high variability of refractive outcomes and the refractive surprises after IOLs in children. This is the graph showing the myopic shift in those patients. And you see most of the myopic shift happens in the first 2 years of life. So you need to compensate for this while implanting an IOL in those patients. This is a table for the side effects that happened between the two groups. The patients who were treated for the first 2 years of life only with contact lens and those who had an IOL implanted. Actually, I will not go through all of them, but there wasn't really any statistically significant difference between the two groups. But we know that for those who had an IOL, we definitely had a statistically significant number of secondary procedures. Mainly, we are going to clear the visual axis in those who had an IOL, as well as the higher chance of glaucoma in those patients. Okay, the second study, which is the PRISH study, but actually, by the way, the two studies were ongoing side by side. The findings of this study indicate that intraocular lens implantation does not confer better visual acuity or protection against postoperative glaucoma, and conversely increases the risk of requiring earlier operation in children younger than 2 years with bilateral unilateral cataract. So they recommend that the use of intraocular lens implantation in this age group below the age of 20 years cannot be recommended. But again, it has very, very known drawbacks. Actually, digging into the literature, I can say that this is the only well-controlled study talking about or answering the question, should we implant an IOL in those children below the age of 10 years or not? And the conclusion was that the incidence of postoperative complication was comparable between the two groups, except for a higher incidence of posterior synechiae in the pseudophakic eyes. Also, visual rehabilitation was faster in the pseudophakic group, but the visual acuity 5 years after implanting the IOL or using the contact lens, the results were the same. So the choice is yours, actually. Okay, so if you're not going to put an IOL, then you have to put a contact lens. And this is a major issue in dealing with congenital cataract patients. We have the rigid gas permeable lenses. We have the silicone elastomers, where we know that if you are putting this lens, then you will have really good corneal deposits. If you are using the hydrogel lenses, they are really keratotoxic because the central part is gas impermeable, even though they are really cost. And the most important issue with contact lenses are their side effects. They could be very mild, as giant papillary conjunctivitis, corneal staining, vascularization, or abscess. And the most important issue when dealing with these contact lenses in our part of the world is availability and compliance. So if you decide not to put an IOL for a patient, you have to find him a solution, especially if you are talking about unilateral cataract. Okay, this study is under review. This is actually my study. I reviewed my own cases over the last 15 years that I did for unilateral congenital cataract at the Jordan University Hospital. And I'm looking only for the complications following implanting an IOL for unilateral cataract below the age of 1 year, with a minimum follow-up of 6 years. And these were my results. You see that the chance of amblyopia is really high in those patients because we are talking about unilateral cataracts. Almost half of them, they needed a second surgery for visual axis opacification, and 1/4 of them, they needed a third surgery for that. And these are the other complications that you will encounter, even going into thesis in those patients. Okay, so if you are going to implant an IOL in those patients, what are you going to implant? Well, before implanting the IOL, this is really what you prefer to see when you are going to implant an IOL. So a lot of times we see patients who had a wonderful congenital cataract surgery done by an excellent surgeon where he removed the lens as well as the capsule. So it's a very neat surgery, a very nice surgery, but you do not have anything to implant the IOL. And that's where we go for either iris fixation IOLs or my preferred procedure of doing Yemeni for those patients. But you have to remember that these patients have still a growing eye. Also, you might see this presentation where you will see the etching pairs, you will see the epithelial cells in the anterior phase of the vitreous if you are not doing a good anterior vitrectomy in the time of surgery. So just before going to what type of IOL you will implant, we have to remember that biometry in those patients is not easy. He's not a very cooperative patient who will just sit for your IOL master. And we are talking about the eye where the axial length will not gain its adult or near adult size maybe before the age of 10 or 15 years. But most of the change happens before the age of 2 years, actually. So the axial length of the eye starts with 17, and you will not reach the 22 or 23 number by the age of 4 to 5 years. Also, we are not only talking about a short eye, we are talking about a very steep cornea. And this corneal diameter, it will not reach its nearly average numbers before the age of 2 years. And this is actually the age where we have to deal with those patients to implant the IOL. So you have to be very cautious with what power you will implant. There are a lot of methods how to calculate the IOL in those patients. One of them, which is very easy to remember actually, is you just undercorrect the IOL power because you are you know that there will be a myopic shift for these patients. So this is one method that was suggested by Vazavada, where for the first 3 months of life, you just down your numbers by almost 1/3. And between the age of 1 and 2 years, you just down your numbers by 20%. Another well-known method is the rule of 7, where if your patient is 1 year old, then you just aim for a +6. If your child is a 7-year-old, then you just go for plano, and you divide that in between. Okay, which eye oil you will implant? Well, we know that hydrophobic acrylic intraocular lenses remain the favorite for the majority of us in cataract surgery, and according to that, you just name it. Name any hydrophobic acrylic eye oil you would like to implant. Will you put it in the sulcus or in the back? Well, the study says that there was no significant difference between implanting the lens in the bag or in the sulcus. But you have to be sure that you adjusted your IOL powers. But the photos that you see are my patients. If you do not want to see this, then definitely you need to put the IOL in the back. The problem is if you were not able to, then you need the 3-piece IOL to put it in the sulcus. Okay. The last thing when doing the surgery is, should we close our wound or not? In adults, we usually do not. In children, I think we have to. I personally prefer to use the tenovacryl simply because I do not have to need to put my patient back to anesthesia to remove them. But if you do not have this available, then you have the teno nylon. But we definitely need to close our wound. It's not very uncommon to have a leaky wound after you do surgery. And please do not forget amblyopia. I mean, talking about this slide might need another webinar. Okay. Before summarizing, actually I saw this patient 2 weeks ago. He is a nephew of one of our very nice opticians. And she called me on the phone and told me, well, I have my nephew, he is 6 months old. She had infrequent esotropia in one eye. And just yesterday, her grandmother noticed that she had a leukocoria. Well, this is her refraction. It's -15 in the what we think is the good seeing eye, and there is no view in the left eye. This is her biometry. We really do not see that much of a difference between the two eyes. Maybe there's as you see, there is some difference in the axial length, but this does not explain this huge difference in both eyes. What are we going to do? What we will do? We will see what we'll do after the COVID. But once you see such a patient, you know that the easiest thing to do for those patients is just go in and remove the cataract. But doing the surgery will be just the beginning for the problems in those patients. Okay, so my take-home message is, I just want to say that congenital cataract surgery is a little bit different than doing cataract surgery in a small eye. Visual rehabilitation post-cataract surgery is as crucial as doing the surgery itself, and you really have to be prepared for all the possible complications. I would really like to thank everybody who was here for this webinar to be live and virtual. Middle East Eye Hospital, Dr. Musa Baydoun, Dr. Zakaria Tamimi, جمعية أطباء العيون, Jordan Ophthalmological Society, Dr. Muad Arabiyat, and definitely our host Orchidia. They were just a great team. And thank you very much, and stay safe.
Thank you, Dr. Mu'taz. Please, who want to ask, please just press on speak, and they are going to answer you. Please, any doctor who want to ask, please. Okay, Dr. Muad Arabiyat. Dr. Musa. Dr. Musa. Dr. Musa.
طيب دكتور زكريا, till Dr. Musa is here, I can see some of the questions on the chat.
Yes, please start. Patching both eyes pre-op for how many hours?
Well, as I said in the presentation, I'm not patching both eyes because I want to, but if you have a cataract in the unilateral cataract in a patient who is 2 years old, and he has any other issues like a congenital cataract, congenital heart disease, or you need to simply he has an infection and you have to postpone your surgery till he's clear of his infection or is cleared from the anesthesia team, then patching both eyes till he goes for surgery for 3 or 4 days is definitely a good idea rather than leaving him with complete unilateral cataract. But definitely I will not patch both eyes for 1 month or 2 months. Dr. Iyad, are you doing iridectomy during the procedure of cataract? Well, actually, I don't. And I do, if there isn't any indication for that, then really you do not need to do that. There are 3 or 4 studies comparing pars plana lensectomy with anterior approach. And the drawback for doing an anterior approach for those patients was that most of the complications were related to the iris. So I really prefer to keep the iris as virgin as I can because you might need it in the future. What about the calculation for IOL for children? I think I covered that in a very simple way. But as you said, it's not easy to calculate an IOL in a child. Whatever formula you say is wrong. I personally use the third generation. I usually use the SRKT for those patients, but you really need a good case. One of the issues that we have to remember when doing biometry in those patients, if you are going to measure the case, if you are doing an indentation applanation for doing like an A scan, then even a minute pressure on the cornea might give you a 4 diopter change in the postoperative IOL. So you need case, you need the axial length, and there are a lot of online sites that can help you with doing your calculation. But for me, what really matters, what is the most important variable for implanting an IOL is the refraction of the other eye. If you are talking about a unilateral cataract.
بليز اي دكتور حابب يحكي بس بعد ما يعمل على البريس على السبيك يتاكد انه المايك عنده شغال. دكتور معاذ. دكتور رائد شطناوي تأكد إنه المايك شغال عندك. You welcome please. دكتور معين. دكتور معين please. ماشي دكتور. الدكتور موسى بيضون. هاي دكتور رائد شطناوي. الدكتور موسى. دكتور موسى تفضل.
مساء الخير.
مساء الورد.
دكتور معتز الله يعطيك العافية.
اهلا يا هلا.
أنا الدكتور معين النوتي. دكتور
هلا دكتور معين، يا هلا.
الله يسعدك ويخليك. حكيم، بالنسبة للاي او الز شو الترند بالنسبة لموضوع ترايفوكال اي او الز؟ Can we use it in congenital cataract to save the near vision?
Well, I just saw في another question. Question from Dr. Ma'in is can we use trifocals or multifocals in pediatric or in congenital cataract? The same question was raised by one of our colleagues in the chat, actually. Well, if you ask this question to a pediatric ophthalmologist, then he will tell you definitely not. If you ask this question to a refractive surgeon, then he will answer you, yes, why not? Being both a pediatric ophthalmologist and a refractive surgeon, I will tell you there are 3 or 4 reputable studies so far talking about implanting multifocal IOLs in kids. But going back to implanting multifocals in adults, the first or the second slide in any presentation talking about multifocals in adults after the financial disclosure will be you need a perfect patient for the perfect IOL, and definitely kids are not the perfect patients. So for me, the short answer is no, and the long answer is you really have a lot of obstacles implanting multifocals or trifocals in children. That does not mean that people tried that, but you are still talking about, if you are talking about a diabetic patient who has a macular edema, then you are not going to put in a trifocal for him, because even these 5 or 10 microns will affect his visual acuity. So imagine that in a child whose axial growth, axial length might change 3 or 4 millimeters while he's growing. So for me, no.
Okay, thank you.
You are welcome. هلا.
دكتور موسى تفضل. Press on mic, please. On mic. دكتور موسى.
يوسف تعال العب.
طيب ممكن اسال دكتور زكريا؟
تفضل دكتوري.
دكتور رائد شطناوي، الله يعطيكم العافيه جميعا. Thank you everybody. Thank you دكتور معتز, دكتور وسام for this very nice talk صراحه. And thank you Dr. Zakaria for this nice moderation. And thank you all sponsors. My question to Dr. Mu'taz, and actually it's my comment about pediatric cataract surgery, is actually I don't advise using or doing the hydrodissection because sometimes in total cataract, in a child with total cataract, you don't know whether the cataract has started in the posterior pole, in the posterior polar or not, and then progressed. So I don't advise. If you are doing bimanual technique, then there is no need to do hydrodissection at all. In this case, you will avoid the dangerous complication of posterior polar cataract and posterior capsule rupture and maybe dropped lens material. The other comment, Dr. Mu'taz, I tried and I used 10O vicryl suture in the past. Their problem that they usually undyed. يعني ما عليهمش صبغة, they don't have a color, or they lose their color during the surgery. This will make the visualization of the suture material very difficult under the microscope. Because you are bringing the child in 2 weeks' time for examination under anesthesia, then you can use the 10O nylon. It is a black color, easily seen, and you do the examination under anesthesia, and then you remove the sutures at the 2 weeks follow-up under anesthesia. What's your comment about this, Dr. Mu'taz? إذا سمحت. Thank you.
Well, thank you, Dr. Raed. Regarding the hydrodissection, as I said in the presentation, I personally do not recommend doing hydrodissection for any type of congenital cataract, as I said in the presentation. So I cannot agree more than what you said. Regarding the tenovacal, well, actually, I do not bring my patient for examination under anesthesia unless I really need to. So the main advantage of using the tenovacal is actually not to bring him back unless I really need to do that. I know, as you said, it's monofilament. It's not multifilament. Well, if you get the ethicon, then you are lucky. But the others, they are not dyed, as you said. But I prefer having that difficulty myself in trying to find the suture rather than bring him back in 2 weeks to remove the tenoanile. But I agree, what you said is right.
Thank you.
ليش ما في صوت؟
دكتور موسى تفضل. يس تفضل دكتور.
مرحبا.
You are online. سامعينك دكتور.
الو مرحبا.
يلا دكتور.
سامعني؟
سوري.
اهلا دكتور موسى. تفضل.
دكتور زكريا مساء الخير. دكتور وسام, Dr. Mu'taz, thank you very much for this very nice lecture and very nice presentation and schematic illustration of two major topics concerning major number of ophthalmologists. Actually, I have some comments. One question for Dr. Wissam and one question for Dr. Mu'taz. Dr. Wissam, I wanted to ask, please, some practical aspect of collagen cross-linking in regard to the limitations of doing this procedure for keratoctasia with flap surgery, and another question regarding implantation of Toric ICL after cross-linking in concern to specular microscopy and endothelial cell count and the depth of the AC. And my question to Dr. Mu'taz, regarding doing posterior capsulectomy in congenital cataract. Actually, I've done few cases in my experience. I do not do primary rupturing of the posterior capsule to avoid doing anterior vitrectomy and to avoid the development of complications such as glaucoma later on when you implant the IOL in the sulcus. Actually, what I've done just to implant the IOL in the bag, and later on, when the posterior capsule opacify, I am doing YAG laser capsulotomy under GA in a manner that the anesthetist and his assistant, they hold and carry the baby, and they put his chin and his head on the YAG laser, and it went actually nicely in many cases. And in that case, you avoid interference with the vitreous and avoid the complications of the vitreous loss. Thank you. Thank you.
Can I start?
Sure.
Yeah.
Yes, please, Dr. Musa.
Dr. Musa, thank you again for the kind invitation, and it's an honor to be always with you in such scientific sessions. As you said, there are some technical limitations for the cases that you alluded to. Patients who are having post-LASIK ectasia, we should always keep in mind that they have a flap that can dislodge with the aggressive manipulation of during cross-linking. The way I do it actually in such patients, either I do it myself with very gentle removal of the epithelium using alcohol. Usually I use 20% alcohol for 20 seconds and make sure that, again, the diameter of the wheel I use is larger than the flap itself, so I don't harm the flap. Again, the key is very, very, very gentle manipulation. If you want to go for the epithelium, which is again even a safer procedure, you have to keep in mind that you need to monitor your patient even more closely, because you know that the efficiency of the epi-on technique is not as good as the epi-off technique. So again, the patient stage determines which technique I will go for. If the patient is in early stage of ectasia, still he has the time to be followed up, so I go for the epi-on technique with a close follow-up. If the patient is having advanced post-LASIK ectasia, no, I will do the AP-off technique with the special precautions I just mentioned. Now, for the toric ICL, of course, always having the shallow anterior chamber or having low endothelial cell count is a concern for ICL in general. But remember, in those patients, two things. First of all, those are keratoconus patients who do have, in most of the scenarios, deep anterior chamber. So usually anterior chamber depth is not a concern. And they are usually young. They usually have good specular endothelial density. So I'm really not considering those 2 points as concerns for toric ICL in keratoconic patients. But again, you should respect the cutoff points definitely for the anterior chamber depth as well as the specular microscopic count. Thank you.
Thank you.
Dr. Musa, again, I cannot say more than what Dr. Wissam said. Thank you very much for the organization and the invitation. Going back to congenital cataract, if we are talking about children who are below the age of 3, let's say, or below the 4, actually there are 50 or 60 studies discussing the incidence of PCO in congenital cataract patients, and the incidence is 100%. So we do, but we do the posterior capsulotomy for 2 reasons. The second is the most important. First of all, we do it because we need to get access to the anterior vitreous. And the second is because we definitely need to do anterior vitrectomy. If you just do posterior capsulotomy in those patients without eating at least 20 or 30% of the anterior vitreous, then definitely you will get visual axis opacification, which is the most important reason for going again and again for surgery. So we are really trying to decrease the number of going into the OR in those patients. So definitely you need to do posterior capsulotomy, and definitely you need to do anterior vitrectomy. As you said, if your patient is a 3 or 4 year old child, actually the youngest child whom I did YAG for was a 4-year-old child. And I thought he will be good enough to sit for a YAG if we needed that. And he needed that in one eye, and he sat on the YAG. But most of them, they cannot. Then that's, if you have to do something for them, then you have to put them back into general anesthesia. But the YAG will only do the posterior capsulotomy, and it will not do the anterior vitrectomy. So I'm just trying to saving them another surgeries. That's the main rationale behind the posterior capsulotomy and anterior vitrectomy.
Okay, thank you. Thank you very much indeed.
Thank you very much. Thank you to all our colleagues. And thank you, Dr. Musa, Dr. Mu'adh.
Thank you for the organization.
العربيات دكتور وسام شحاده، دكتور معتز غرايبه، شكرا لكم كثير وإن شاء الله.
شكرا.
أكل كتير، رغي كتير، شغل كتير، انفلونسرز كتير، جيمز في الحمام، هاي سكور، تلفزيونات في الجيم، ماب في العربية، سكرينز. بنقضي نص اليوم باصين على سكرينز، وده ممكن يأثر على العين ويسبب لها جفاف. استخدم بولي فريش.
Thank you to our colleagues. Thank you very much, Dr. Mu'taz, Dr. Wissam, Dr. Musa Baydon, Dr. معاذ عربيات. شكرا لكل أساتذتنا الكرام. نشوفكم على خير إن شاء الله.